You are remaining speakers for the breakouts this afternoon, Dr. Rebecca Taylor and Dr. Jason Scoppa. Dr. Taylor holds a bachelor's degree in molecular and cellular biology from UC Santa Barbara and her dental degree from the University of the Pacific Arthur A. Dugoni School of Dentistry in San Francisco. She studied with the IAOMT, became an accredited member of the IAOMT, and certified in safe mercury removal. She attended the American College of Integrative Medicine and Dentistry, making her a board-certified naturopath, and obtained her degree in integrative biology and dental medicine. She also completed her coursework through the Institute of Functional Medicine and is certified in ozone and myofunctional therapy. She's a member of our academy, the IABDM, the Holistic Dental Association, the International Association of Orthodontics, and Dr. Jason Scoppa is a certified SOT craniopath and SOT chiropractor with a TMD focused practice in Bellevue, Washington. Aside from SOT, he is certified in applied kinesiology and chiropractic sports medicine. He sits on the board of SOTO USA and has been an active member in a prominent orthodontic study club in Seattle since 2017. In addition to private practice, Dr. Scoppa teaches SOT and cranial dental co-management courses and has an online education company geared towards healthcare professionals and bridging the gap between chiropractors, physical therapy therapists, myofunctional therapists, and dentists and orthodontists. Please give a warm welcome to Dr. Rebecca Taylor and Dr. Jason Scoppa.
So sorry. Thanks everyone for being here. I think you did an amazing introduction, so I'm not going to say much more about how awesome we are. But I did want to apologize in advance. We have a lot to go over with you guys. It's super awesome and exciting stuff. So I'm going to be talking fast. We're going to go through stuff. And if you have questions, we're going to be doing the questions later, I think at 5. Or if you see me or him walking around, come talk to us. Like, we love to, talk about what we do. So, okay.
Again, my name is Dr. Scoppa. I really appreciate you guys having me, and I wouldn't be able to do what I do with any degree of success without the help of you all, and we'll kind of go through that later. But I think chiropractors and dentists, especially dentists doing TMD and occlusal work, I think we need each other, and I think a lot of cases are much easier when we work together. So I have a private practice in Bellevue, Washington, and I started Classava to educate both groups and bring them together. You did a good job introduction, so that's all I got to say about that.
All right, and then I'm Dr. Rebecca Taylor. I'm the owner of Green City Dental. We are a holistic biological dental practice in Edmonds, Washington, about 20 minutes north of Seattle. And then I also have a practice called Otodontics. We only do TMJ, airway, and orthodontics. So that's my background. So 1 out of 3 of your patients in your office suffers from a symptom, any of these symptoms. These are all TMD types of symptoms. And one of the things that I think, I don't know about you guys, but when I started to treat TMD, you meet other types of practitioners, and everybody kind of thinks that they know exactly what they're doing when it comes to the TMJ patient. The dentist is going to make an orthotic, or they're going to make a bite guard. They think it's all occlusion. The chiropractor thinks it's an upper cervical issue. The physical therapist thinks that it is a muscle issue. And so the acupuncturists are like, well, I can fix that with my acupuncture. We have all of these people that are focusing on this little tiny piece of this elephant without really zooming out and looking at the bigger picture of what's actually going on. So I'm going to pass, hang on. So the takeaway concepts today, we really want to drill into you guys why it's so important that you have an integrative model when you deal with TMJ and dealing with occlusal dysfunction. I want you guys to understand how TMJ issues develop in the first place, and then treatment pitfalls. So how can you guys go home on Monday morning and make sure that you're up in your TMJ game? So when you have a patient like this, who walks into your office who got her braces off 2 weeks ago, now she suffers from a lot of neck pain and back pain, you know what to do. And this is where we have to have that integrative model. It's so important. All right, I'm going to pass it over to you.
So again, yeah, we apologize. There's just so much to go through, so we're just going to like touch on a lot of topics. And said I'd happy to talk more later for anybody that wants to chat more. But these are just really quickly some important factors to consider when you've got a patient, especially one with TMD, but anyone that you're doing any kind of occlusal work on as well. But I mean, how does the cranium develop? Not just the Weston A. Price work and the nutrition work, but literally how does it develop? What are the directions of growth? How do you stimulate growth and remodeling? What's the difference between growth, remodeling, distortion? These are all questions I feel like if you're going to say that you're going to do expansion, you're going to be working with an underdeveloped maxilla, you should be able to answer these. This should be like 101 questions. Dynamic versus static alignment, what does that mean? Importance of propagation. Ascending and descending patterns, a lot of things affect bite that are coming up, and then a lot of the bite will affect a lot of things going the other way. And what does that look like? Cranial dental considerations, and then balancing a pain patient versus an orthodontic patient. So some patients aren't in pain, they just have, a bad bite, ugly smile, but they're not in pain, versus someone who comes in and they are in pain. How would you look at those patients differently? Main goals of the co-management, said correct ascending influences on the bite and condyle position. So I list some studies in here later. But there's the best example. There's a couple of repeat studies that were done out of Japan where they took people with equal leg length, no jaw pain, had them walk around, measured occlusion, and then they put a heel lift on one side, had them walk around for a while, and on the side of the heel lift, they started developing jaw pain, and it changed their bite on that side. So even as far away as leg length, we know can affect the bite and the condyle position. Leveling, the whole concept of leveling the maxilla. Who's familiar with that? I know there's quite a few people that teach that. So if you're trying to get a bite, if a patient's occluding and they're hitting harder on the right side, do you shave the teeth down on that side to make the occlusion fit and then call it a day? Or do you look a little bit more broad? Correct cranial strain patterns. So how do those develop, right? The cranial bones. The dura attaches to the cranial sutures. That dura can torque the cranium. The bite can create cranial strain. So you see people come in and their eyes are unlevel and their shoulders unlevel, and that can be caused by the bite, but the cranial strain can also influence the bite. So before you set somebody's occlusion, it'd be good to get those unwound, right? You'd have a better idea of what's up and down, and the person would have a better chance of having a successful treatment and retention. Stimulate or relax muscles in and around the neck. Muscles move bone, as we know, and can guide bone growth. That's really important. And the muscles, more often than not, are what's causing the patient's pain, so that's really important to address. And then just other things, important things to take into account, the maxillary deficiency, right, underdevelopment of the maxilla, either A to P or lateral or both. Airway compromise, nasal or pharyngeal, myofunctional issues with the tongue, obviously a really big deal. And Dr. Taylor will get into that a little bit more later. Is the TMJ joint degenerated? And most of all, what are the patient's goals? I mean, a patient could come in and see me, and they've got a ton of neck pain. Their jaw's clicking and popping. It's just a total disaster. And I could be like, wow, you need to go see Dr. Taylor. This person needs a full remodel job, right? This person needs everything. But the person's like, I can't afford that. I can't do that. So what do you do with that patient, right? You try to meet people where they are. If their goal is to get out of pain, then we do that first. And then, a lot of times you gain their trust, and then they'll be open to do more down the road. The patient's age too, right? If someone's like 80 years old and they come in, probably not going to be doing expansion and the full thing on that person. We just want to get that person comfortable so they can do what they want to do.
So we were curious about how important the cranial work, or what kind of impact the cranial work actually has on the muscles and then the function of the bite. So we did this little study where we put these little electrodes on all of the muscles. So we put them on the temporalis, put them on the masseter, anterior digastrics, and then upper cervical group. And we did EMGs. So we did EMGs on the muscles before any cranial work, and then we did them after. So I'm just going to show you what you're looking at here if you're not familiar. Is this my laser? Okay, yeah. Okay, so up here, these LTA and RT, this is the temporalis. Okay, so this is the left temporalis, this is the right temporalis. These numbers here are kind of the ideal numbers for where we want the muscles and how we want them to be firing. So these are the temporalis, these are left masseter, right masseter, cervical group, and then the digastrics, okay? So you can see on this side, this is how this patient presents. So this is at rest. This is close your eyes, relax your jaw, and just, we run our scan, okay? So we can see here that the temporalis muscles are definitely elevated, the masseter muscles are elevated, the cervical group is elevated, and we have some elevation slightly in the anterior digastrics. Okay, so we were curious, does the cranial work do anything to these muscles? You know, we didn't know. Like, we think it does, but we wanted to test it. So we had, Dr. Scoppa came in, he treated this patient. How long did you treat her for? 15 to 20 minutes. And then we ran the same exact EMGs on the muscles again. So you can see that all of these muscle values have really dropped down, except for this one. But you can see that everything is kind of normalized. So I think the important thing is that the muscles, we can get everything functioning the right way with cranial, but in order for this to stay like this, we've got to make sure that the occlusion is stable. We've got to make sure that the bite will support this position. So if you have a patient that's coming into your office, you know, like this, and you're not doing any of the cranial work, and you're not helping to level the maxilla, then you're going to be making them in an appliance that just is in this muscle position. So I think this is really cool, and we're going to do more. We did several patients, actually, and we put the EMGs on, and it was the same. We found the same results. So we're going to keep messing with it. Our next one is we want to see how long does this stay like this before, like if a patient goes and eats a sandwich, what do the muscles look like after they went and ate a sandwich, right? So we want to know how fast does this go back to this?
So yeah, I want to reiterate that as well. I mean, the work, that work, I can get a good result on a patient like that, and I can feel it. And it was really cool to see it actually, numerically represented. But that will not hold. I mean, that's been my experience for most patients. I don't, some people, we're gonna try and do a study, but I imagine some people it'll last a day. Some people it might last an hour. I don't know, but that's why I said I need her help to kind of put a placeholder into what we just did, and then we kind of work together till those numbers become like that in range, and the patient's symptoms are better. So this is a patient that I saw, for about 10 months. So this was just cranial work, and then some basic myofunctional therapy stuff that I gave the patient. I basically just told the mom, if he's got his mouth open, close it, and trying to get him to get his tongue to suction up, play some games with the tongue. But made some pretty good progress. I mean, that kid on the left looks terrible, doesn't he? I mean, his airway, he's got forward head posture. You see he's got a hyperactive mentalis muscle, so he's not swallowing correctly. This looks tired, and his midline's way off. He was grinding, clenching a lot. And then 10 months later, he looks really good. Midline's still a little bit off, but pretty good. Do you have the? Oh, perfect. It's easier to get this result. These are both children, obviously. And an adult, this would not be like this. This is another little girl I treated. So this is just cranial work and some basic myofunctional principles. But we got her. When she started breathing correctly, lips together, breathing through her nose. You can see her maxilla was tilted there on the, which is the laser. Is this the laser? There it is. You see how see the difference between this side and this side? And you see how it's more equal? So her maxilla was dragging down to the left side, and her mandible is too, but you could see how it leveled out there. And she's got a lot more width as well. But see, see how she's still A to P deficient, right? That's not right? So she's still going to need some help. But gosh, it's a lot easier for you guys to start from here versus here, right? I mean, isn't that an easier case? I mean, so big questions. How can you find a neutral bite without accounting for ascending influences, cranial strain, maxillary malposition, and functional distortions? And then, you know, in terms of like phase 2 work, how can you expand and take into account, you know, ascending influences, cranial dural torque, and an unlevel maxilla? I just think it'd be really difficult to, you know, I know you guys are amazing, but it'd be really amazing. And then to get it to hold, it'd be pretty tough. I mean, our eyes are always going to try to stay level on the horizon. That's the main thing. So if you know, you're distorted all which way, your eyes are going to be level. Everything's going to distort around that. So you'll see different cranial strain patterns and different patterns in people laying down versus sitting or standing, because gravity's not in the picture, right? So proprioception is sending all those messages to the brain to get the muscles and the joints, and everything's kind of going all around that to keep that vestibular writing mechanism on par, on level. How many impetus, like how many impulses do you think come in to our sensory cortex every second to deal with? What's a guess? 6,000? Anybody else have a guess? Come on. A million. One. Well, okay. 3 trillion every second. How many of those are you conscious of? That's including pain. How many of those are you conscious of, you think, out of the 3 trillion? 6,000? A million? 50. 50. So you can't count on pain to be your main indicator. Sometimes you have to have other ways of looking at things functionally. So we're only aware of, you know, this much of what's going on in terms of what our body's taking in. It's filtering it for us. But sorry, these are really small. I just tried to fit on as many as I could. You guys are going to get this, these slides, but if you want, these are just some studies I found, like that Japanese studies on there, just some studies about changes in the condyle position in the jaw, and then some where it's the reverse, the stomatognathous system's influence on the rest of the neck and the pelvis and the rest of the body. So sorry that you can't really, I just tried to fit as many as I could on there, but when you get the slides, hopefully, if you're interested, you can look at them. But there's more. But it's a good start.
All right. So why do 1 out of 3 of our patients have TMJ issues in the first place? I am always asking myself, being a biological dentist, I'm always asking myself, what caused all of this to happen? And I never thought going into practice that I would be treating kids. I thought I would be done after dental school. But when you start to zoom out and you look at why we have issues with TMJ, why we need orthodontics, why do we even have airway issues, all of that starts in a growing child. So to truly be able to correct and change, we have got to treat kids, and we have to do early intervention. So when we have dysfunction in our breathing, when we have dysfunction with our tongue and our tongue is laying down, or maybe we don't have a tongue tie, but maybe we just have a habit of breathing through our mouth, that's going to cause the maxilla to collapse, and it's going to create more of this class 2 retrognathic profile. And what that does is it causes the lower jaw, the mandible, to have to shift back. So in order for your teeth to come together, the top jaw, the bottom jaw has to fit into the top jaw. So it will naturally go back so that it can fit into this position. The problem with that is that when your jaw is constantly being protruded back, your temporalis muscles are on fire. And the muscles, 90% of our TMJ symptoms come from the muscles. So we have to treat the cause of the dysfunctional muscles in order to get really great clinical outcomes. So if we have a patient like this that presents into our office, you guys see this every day, and they say, I have neck pain, I have back pain, my jaw is clicking and popping. Like, what do we do with that person? So we take our appropriate records, but let's look at this patient. So she's got really heavy anterior contact here. What does that tell us? It tells us that the lower jaw is back. Okay, this is going to cause occipital pain, neck pain. We can also see that she has much higher occlusion on the right side, and the left side doesn't hit as much. What does that mean? That means that for her, when she bites down to chew, she has to force her muscle to get these teeth together. And that's going to create an enormous amount of torque in the cranium. And so when we see a patient like this, we also see, look at these second and first molars. I mean, she's just grinding the hell out of her teeth, right? So what do we do for this patient? I'm going to tell you. But most of our TMJ patients, I'd say probably over 90% of your TMJ patients, they have a posterior positioned jaw. So our normal condyle should kind of sit like this, okay? Should have nice cushy space, be on the disc. And in our patients where the maxilla is underdeveloped and that lower jaw is positioned more posteriorly, we're going to see that this condyle now pushes back. Okay, now remember, there's all these muscles that are connected to this condyle, right? It's all one system. So you're going to get a lot more muscle tension and pain when you have a jaw like this. So we really need to make sure that with our TMJ patients that we are positioning this joint and these muscles, we need to make sure that this is positioned in a more forward position to help create more balance in the muscles and less inflammation. So I get people that come into my office all the time. They have a handful of orthotics, appliances, and they're like, how come I keep grinding through my night guard? And I always tell them to put them in, and we measure. We measure to see, is the appliance causing the lower jaw to be retruded? Because if you're causing the lower jaw to be retruded, that's going to make the muscles mad, and it's going to cause pain. So you can see with this patient, we've got, this is them just naturally biting down. This is a really easy test to do, just biting down. And look at, this is now several millimeters more retruded. This appliance is not going to help this patient. In fact, this appliance could make clenching grinding worse, and it could make the patient have more clicking and popping because they're off the disc. So, what do we need? What is the purpose of our orthotic? First of all, the purpose of an orthotic is diagnostic, okay? Every time that I do an orthotic, I tell the patients this is a diagnostic phase. Okay, we're trying to find out if we reposition your jaw, if we can get rid of your symptoms. Okay? It's diagnostic. The point of the orthotic is to reposition the jaw, reposition the mandible in a position where the spine, the cranial bones, the airway, and the muscles are all happy. Okay? It's one system. They all should be winning. And then we also cannot forget about proper occlusion on our appliances. Okay? We have to make sure that our occlusion is not lacking or is lacking any interferences that might cause the muscles to get irritated. So you have to know your occlusion. So one of the things that I tell dentists is when you take your bite registration for your orthotics, get their cast, get their model before you see the patient and draw a line on the first molars. You can draw a line behind here too. And take your bite registration where you believe the jaw needs to go, okay? If this line goes back, throw that bite registration away. It's not the right bite, okay? This line needs to at least stay the same or go forward to heal this joint, okay? This is super easy. Super, super easy. But it will make your clinical outcomes much better with your patients. So a lot of people, I also see patients that say, well, I had my orthotic or my device in, and then it caused my bite to change, and so my dentist told me to stop wearing it because my bite changed. Well, why is the bite changing? Right? So when we reposition the jaw and the muscles are happy and they aligned, and we've created stability in the bite and the cranium, of course your teeth aren't going to come together because the teeth don't want to live there. The teeth want to live somewhere else. So when I see patients with bite changes and all that, but their symptoms got better, that's a sign to me that I probably need to have a phase 2 treatment. Okay, we have to make the teeth support that more functional bite. So if you have a patient like this, obviously he's not going to be done after an orthotic. However, there's no way I'm going to restore his teeth unless I do phase 1. Because again, it is diagnostic. We have to figure out where his jaw wants to be. We have to have him try it out, make sure he feels better, feels okay functioning with it, and then we can put him into something like a phase 2. Okay, this is actually his orthotic, because we had to do a lot on him. But your phase 2 option, so after you've done phase 1, diagnostic, patient is happy, they're comfortable, then you have options, okay? One option is just keep wearing it your whole life. Just wear it 24/7. All right, that's an option. Most people don't like that option. The other option is wean off the appliance. So tell your patients, okay, let's have you stop wearing it a couple of hours a day, and then slowly see if your symptoms come back, then we know that we probably need to maybe do something a little bit more permanent. But you can successfully wean people off of these appliances without them getting symptoms. So you should always try, unless your patient is chomping at the bit to do ortho or whatever. The other thing that you can do as a phase 2 is orthodontics. So a lot of times when we move the jaw down and forward, we're creating a posterior open bite. So what we do is we extrude the posterior teeth to basically, give them that bite that the orthotic is in. Sometimes patients don't want to do ortho. They're like, I'm 80, there's no way. And so we'll do restorative. And the bonding techniques and the porcelains and the composites are amazing these days. You can do super minimally invasive biomimetic dentistry without having to remove a lot of tooth structure. So this can be a really, really awesome kind of, we call it like instant orthodontics, because you can change somebody's bite in just one visit. Also, combo ortho restorative, we can do that. Some people, like this patient who has a lot of crowding, maybe we want to do some ortho first before we do the restorative work. And the other option is a semi-permanent orthotic. This is like a bonded orthotic, and so that's your other option for phase 2. So in our office, I like finding the jaw position with a TENS machine. So TENS machine is going to put a little electrical stimulation into the muscles. It's going to bring all those sarcomeres that are stretched or constricted, it's going to bring them to their physiologically rested position. It's a way to kind of deprogram and take away the proprioception, because every time that the patient bites down, everyone knows where their bite is. So we've got to kind of trick the body, and we've got to distract and kind of unwind this proprioception. So the thing I like about TENS is that it helps with, there's six ways that the mandible can go. We've got the pitch, and so the pitch is like this. We've got the roll of the mandible. We've also got the yaw, okay? And then we've got a vertical component AP. So this TENS machine is going to help us with all of those. And so if you look at this patient, she came in, she's like 13, I think. A lot of neck pain, back pain. Her shoulders are all asymmetrical. You notice her midline is shifted over here, so I know that this left joint, there's something going on in the left joint, probably some internal derangement. I TENS her, and now look what happened. Her jaw comes down and forward, but look at this midline. The midline corrected. So we know that we were able to recapture that disc. So I do this with TENS. I found that that's, for me, the best. And the other thing that I like about TENS, probably my favorite, is that TENS allows us to determine the proper trajectory as to how somebody bites down. So this is a jaw tracking machine. There's a little magnet here, and this measures how the jaw is moving. So when the patient bites down, they're right here. They open, they go like this, and they bite back down. My TENS machine is going to pulse the jaw and move the jaw, and now this is the TENS trajectory. So this patient really needs to be biting on this line in this way versus their habitual bite, which is like this. This is something that TENS does that other deprogrammers don't really do. This gives you literally a pathway and a trajectory, where to put the jaw. So let's look at this patient. She comes in, and you can see that she's looking up this way, okay? When you see patients like this in your practice that have this forward head posture and gazing up, this is really a sign generally that they need more vertical height in the posterior teeth, okay? So you can see once we give her that posterior height, see how that head just straightens out. And this is a much more beautiful profile than this. And we also see that when we do this, this is actually airway dentistry. So airway dentistry is, that term is very, very like thrown around all over. But true airway dentistry, I believe, is making sure that you have a functional airway day and night, okay? So when you put patients in an orthotic to wear, and your airway goes from like this to this during the day, that's a good thing, okay? We don't just want this type of airway at nighttime, okay? When you put the jaw in the right position and the right trajectory, you're going to be doing airway dentistry, okay? It's all the same thing. So let's look at another case. I've got my EMGs on this patient. This is how they present. We've got temporalis. This is the left temporalis on fire. Right temporalis, fine. Left masseter on fire. So I already know here I have this asymmetrical muscle pattern here. And this is what the patient's bite looks like. All right, we're going to do our jaw tracking, relax the muscles, figure out where the bite belongs. We see after our 10s that jaw drops down and forward. But look at, I got all the space here. So what do? I'm going to fill in that space with an orthotic, okay? And that's going to help hold this position and keep those muscles happy. So there's a lot of different kinds of appliances. Everybody always asks me, what's the appliance that you use? And I have my favorites, but I think more importantly than the type of appliance you use is making sure that the jaw is in the right position and that patients can function with their appliances in. All right, so I use MyoLiner. This is the MyoLiner appliance. It's actually a removable appliance. It looks like teeth. It feels like teeth. It snaps in over the teeth. So I do a lot of MyoLiner. It tends to be more aesthetic than something like this. But I also make removable appliances like this too. But basically, my point is many appliances will work, okay? There's not like one size fits all. There is an exception to that. I don't love upper appliances, and there's a couple of reasons. One of the reasons, which I think Dr. Scoppa probably cares about more than I do, but there's cranial sutures in the maxilla, and he can speak more about this. But that, if you're crossing over these midlines and you're creating this tension in the maxilla, that could prevent the maxilla from moving, and that could affect the lymphatic system or the way that the brain detoxes and the lymphatic drainage in the head. Also, all of this acrylic in the upper palate, I don't like that because it takes up the position of where the tongue should be. So proper function is a tongue positioned up in the palate. Well, if you have all this acrylic up here, you're taking up all the room where the tongue needs to go. So those are the two reasons I don't love upper appliances. So here's another patient, comes in. These photos were taken about, 5 minutes apart. So look, forward head posture, look at this mentalis strain. All right, we pop an orthotic in, and look at how relaxed her muscles are. This is a beautiful profile. This is cosmetic dentistry and airway dentistry and functional TMJ all in one. So I like to have my patients fill out a form like this because I want to know when they walk in how bad their symptoms are. This was filled out 1 week later. So you can see how profound your jaw and TMJ treatment can be. It can be huge. So make sure that you ask your patients and have a way to track, because sometimes when you start to get into this type of work, you just kind of, it gets like you're just seeing these patients over and over and you're like, am I even helping you? I don't even know. So make sure you have a way to know if it's helping, okay? And you should see, like I said, results pretty fast. The other thing that you have to screen your airway or your TMJ patients for is their mouth position at nighttime, okay? So remember, our TMJ patients are gonna have that retreated mandible. When you sleep with your mouth open, what's happening to your mandible? It's going back. So this is going to cause lots of strain in the temporalis and the muscles. If you have the most fancy orthotic in there, if their mouth is open, guess what? It's not really working, okay? You're not going to get the same healing. So you got to make sure you screen your patients for this kind of stuff. And you got to figure out, is this a habit or is there an actual physical obstruction going on? I love using mouth tape as a diagnosis tool because I'll have patients try mouth tape and can mouth tape. Then I'm like, that's great. This is a habit most likely. If they can't mouth tape, I'm like, that's great. We need to have you go see the ENT. It gives you more information as to what's going on with their breathing, and then you can help guide them to where they need to go. A lot of times airways are blocked and we have nasal breathing inhibiting because of adenoids and tonsils being enlarged, so look at tonsils. Look at your CT scans, okay? These patients probably need to go see the ENT for you to get full resolution of their symptoms, okay? I cannot emphasize enough how important it is to screen your kids, okay? If you have patients that come in, like, teach them about this with their kids because this is where it all starts. So the other muscle that doesn't really get mentioned a lot in the TMJ world is... Anybody know? The tongue. I never thought I would be talking so much about the tongue, but it's a very important stabilizing muscle. The tongue is connected to the floor of the mouth and the hyoid bone. All those muscles wrap back up to the upper cervical spine. So if that tongue is down, it's going to cause that jaw to be more retruded, put pressure on that upper cervical spine. Every single TMJ patient, you need to look at their tongue, okay? You need to look at tongue ties. You need to look at the function of the tongue. A lot of times it's not an obvious tongue tie, but the function is not there. If you see a patient that has scalloping in the tongue, a lot of times we say, oh, well, they need expansion. This patient, it's too narrow. Well, maybe, but they also could just need more vertical height. So a lot of times if you increase the vertical, the scalloping in the tongue goes away. It's really important that you know where to put that jaw so you know if they're vertically deficient or not. So Dr. Zoggy's in LA, he's an ENT, he runs the Breathe Institute. I didn't really have time to go through all of the tongue-tie diagnosis stuff, but I highly encourage you, if you're gonna treat TMJ patients, that you go take some courses with him. He also teaches the myofunctional therapy that goes along with it. So speaking of myofunctional therapy, this is also a must for patients that are undergoing any kind of TMD stuff. I have a lot of patients that come that they may not be able to afford the orthotic and the full, the full deal type of treatment. So myofunctional therapy has been shown to help reduce TMJ symptoms alone, and it's a great adjunct therapy. So one of the things, this was a really fun screening tool that you can do. So I want to wake everybody up right now, okay? Let's do a little exercise. So I want everyone to open your mouth and try to snore. Okay, now I want you to suction your tongue up in your palate, suction it as hard as you can, and I want you to try to snore. Who can snore? Okay, so if you do this on your patients, if you can't snore, that means that the tongue position and strengthening the tongue is going to help your snoring and your airway. If you do snore when you do this experiment, that means that you probably need a little bit more. You might need some expansion. The palate may be a little bit narrow. So I love doing this on patients because they think it's magic. You like instantly got rid of their snoring. And Dr. Zoggy teaches this in his protocol as well, the screening. So if a patient cannot do the exercise, or if the patient cannot do an orthotic, they just can't for whatever reason, I'm at least going to send them to Dr. Scoppa, and then I'm going to give them, this is a QR code, you can send your patients here, you can go here, but I have these jaw stabilization exercises. They're really easy, they take a couple of minutes a day, and they're very effective at your TMJ, helping with the TMJ symptoms. It may not be enough, But for a lot of patients, it greatly decreases their symptoms. So what does this actually look like in practice? Like I said, we talked about a lot of things and went over a lot of things, and we could probably teach a whole weekend course just on what we talked about in this lecture. But what does this look like in practice? So first of all, you got to screen your patients. You got to ask them, do you have any of these symptoms? Have them fill out a TMJ form when they come in as a new patient or at a hygiene visit, and then invite them back to talk more about their TMJ treatments. I always recommend that people work with Dr. Scoppa before they come to my office. Some people do, some people don't. But if you have people that have any of these things, these are going to be your harder to treat TMJ patients, okay? So this is where you really want to make sure that you're bringing in somebody like Dr. Scoppa who can help you balance the maxilla and do all of that other bodywork type of stuff. Do you want to say anything else about that?
Sure. Yeah, I mean, a lot of it depends on who's in the area too. But I just want to touch on something she mentioned earlier with the patient. That's when the patient bites down, that's sending a message down, right? So if the bite's off, and they're occluding, like the guy you had earlier that was just a mess, that guy's probably going to have a ton of symptoms. So he could come see me probably every day, and he might leave feeling a little bit better, but he's not going to get better, right? He's going to have to fix those other things to stabilize. But once the bite's right, and they have the orthotic in their mouth, they come in, I feel their neck, and it's like butter. And I have them take it out, bite a couple times, I check their neck again, and just like that, their neck is locked up again. So it's just, if you can get their bite right, then every time something else is wrong in their body, every time they swallow, that's going to actually be bringing them back into a healthy place. So I said, it's just, again, reiterating, it's really important to get it from both ends. And yeah, a lot of it depends on who's in your area in terms of who you're able to work with. Not a lot of people do cranial work, unfortunately. We're trying to change that with SOT, and we teach craniopathy to chiropractors. Craniosacral is usually too gentle. It's almost energetic work. It's good. It's not usually enough to actually change the maxilla and the sphenoid. But yeah, it depends who's in your area, and then who you just click with, somebody that you work with, somebody you just enjoy working with. You guys are on the same page. That matters the most, I think. And then you guys can kind of grow together and develop your own protocols, your own way of doing things. But
okay, so patients will go see Dr. Scoppa first. He'll do his magic on them. We like to put cotton rolls in between the teeth on their drive from his office to my office, okay? Because again, if they go eat a sandwich, not a good thing, okay? So we want them to drive straight to my office. Depending on the patient and their symptoms, I may TENS them or I may not. But I'm always going to be checking the bite, okay? The bite changes as the cranium changes. So this is not like a, here's your orthotic or your night guard, bye, we'll see you in 5 years. This is a treatment, okay? So we're checking to make sure that there's no posterior interferences. We're checking to make sure that when they go into protrusive, they're not hitting anything here. We're checking central contacts. We're checking that when they go hyperprotrusive that they're on their canines. So there's different things that I look for, and I make sure that I go down my list of 6 things to make sure that this is an optimized bite for them, okay? Hang on one second. We'll get to questions in a minute. So I'm adjusting these appliances after they come in, and like I said, we typically see symptoms resolve very quickly. Like even within a week, we'll see symptoms resolve. But sometimes as the cranium is shifting and the bite changes, we have to do some microocclusal adjustments to help support that optimal jaw position, okay? So I typically will see patients about once a month, and like I said, they'll go to him and they'll come to me. Most patients, like I said, are gonna get better pretty fast. We want them to be in this phase 1 for at least 6 to 12 months to really make sure that things are stable before we move into any kind of phase 2. So remember, that phase 1, this orthotic therapy, sometimes just the beginning to this much bigger thing, okay? I've had a lot of patients that they get their orthotic their symptoms resolve, they're like, I'm like, you're going to need ortho. You're probably going to need restore. They're like, nope, I'm not doing any of that. But once they see that your treatment works and they get out of pain, they come back to your office and they say, all right, I'm ready for that restorative work. All right, I'm ready for that ortho. You don't have to sell these patients on the treatment for phase 2 because they already have test drove your bite, you've built their confidence, and they come in ready to go. They already trust you. They know you can help them. So how do you get everybody on the same page? I think this is one of the hardest questions because everyone asks like, well, how do I find a Dr. Scoppa in my area? And how do I learn more about like TENS and where to take the bite and all that? So there's a lot of different places that you can learn. I got a lot of I train with a lot of different people, but my favorite was Occlusal Connections with Dr. Clayton Chan. That to me was like the best bang for your buck and just solid. In terms of the chiropractors, Dr. Scoppa actually teaches chiropractors. So if you have a practitioner that you like to work with, then get them in contact with Dr. Scoppa, and he's happy to talk with them, and they can go through his certification course. All right. Well, thank you all for listening. Really appreciate it.
Thank you, Dr. Taylor and Dr. Scoppa. Will you be up at the speakers forum at 5 o'clock? So if you have more questions, we have a few for maybe 1 or 2.
6 minutes for questions.
Okay, 6 minutes for questions. Let me give you the AGD code, completion code. TMJ as in temporomandibular joint, 32224, RJ as in Rebecca and Jason, TMJ 32224, RJ. So we have a few minutes. Does anybody have a question?